All right, good night, everybody. My name is Damani Joseph, and tonight I'll be presenting on the pituitary and the HPA axis, or the hypothalamic pituitary adrenal axis. So the outline for this talk, first we'll just introduce the topic. We will go through an overview of the HPA axis. We will discuss the anatomy of the pituitary and the hypothalamus. We go through the physiology of the HPA axis, discuss the stress response, HPA axis dysfunction, and go through a diagnostic framework. So the hypothalamic pituitary adrenal axis is the primary neuroendocrine system for responding to stress, regulating vital functions like immunity, metabolism, mood, and energy. So in this slide, I'll just go over some points as to why appropriate knowledge of the HPA axis is important to the neurosurgeon. So it's important in terms of understanding how the body reacts to surgical stress. So major neurosurgery can cause significant physiologic stress, which would trigger the HPA axis to increase cortisol release, which is necessary to maintain hemodynamic stability. Understanding the HPA axis is important in identifying and or preventing acute adrenal crisis. So patients with pituitary tumors or those on long-term corticosteroid therapy may have a suppressed HPA axis. So failure to identify this and provide stress dose steroids can lead to life-threatening adrenal crisis. It's important in perioperative care for pituitary tumors. So surgery on pituitary adenomas can directly disrupt the HPA axis. Postoperative monitoring of hormones like adrenocorticotropic hormone and cortisol levels would be essential to manage potential temporary or permanent hypoadrenalism. In the neurotrauma and critical illness, so patients with severe traumatic brain injuries or other critical neurosurgical conditions, the HPA axis may be dysfunctional. Some studies in the past would have suggested steroids for edema or swelling in the brain. There are some current evidence, such as from the Brain Trauma Foundation, that does not recommend their routine use in traumatic brain injuries. And finally, in neuroinflammation regulation. So chronic stress and HPA dysfunction, as seen in some neurosurgical patients, can result in high cortisol levels, which cause neuroinflammation and atrophy of the hippocampus, which can worsen neurologic outcomes. Right, so this is just an image that is outlining an overview of the HPA axis. So activation of the HPA axis is initiated by the hypothalamus, which can be activated by perceptions of threat, stress, as well as internal physiologic processes. This activation leads to the release of corticotropin-releasing hormone, which stimulates the release of adrenocorticotropic hormone into the vascular system from the pituitary gland. This in turn activates the adrenal glands, which are situated atop the kidneys, to secrete glucocorticoid hormone cortisol. When the blood cortisol level are sufficient or high, this via negative feedback suppresses the hypothalamus from releasing the corticotropin releasing hormone and the pituitary gland from releasing ECTH. So that's just a brief overview of the HPA axis. We'll move on to the surgical anatomy of the pituitary gland. The pituitary gland sits atop the base of the skull in a concavity within the sphenoid bone called the sella turcica, or the pituitary fossa. Immediately below would be the hypothalamus and the optic chiasm. In young individuals, on average, the pituitary gland measures around 12 millimeters wide to 8 millimeters in anterior posterior diameter, and it can be 9 millimeters long. But this size does vary significantly with age, gender, and even hormonal status, such as in pregnant females. The anterior lobe of the pituitary is surrounded by a thin fibrous capsule, which is similar to that of the salivary glands, and it is continuous with thin septae, which extends into the gland itself. The pituitary is usually divided into anterior and posterior parts. And it actually refers to groupings of four subparts. So the anterior pituitary or the adenohypophysis will be broken down into the pars distalis, pars tuberalis, and the pars intermedia. And well, the posterior pituitary is otherwise known as the neurohypophysis. The pituitary fossa is surrounded by a layer of dura, which is continuous with the diaphragm ocelli above. The diaphragm ocelli has a variably sized opening for the infundibular stalk, and it's not uncommon for the diaphragm ocelli to be incomplete, which can be considered a normal variant. CSF can enter into the pituitary fossa and give rise to something called an empty cellar sign on neuroimaging. Just to go in a little bit on the anterior pituitary, it is by far the largest part of the gland and is responsible for the synthesis and release of most pituitary hormones, with the exception of oxytocin and antidiuretic hormone, which is secreted from the posterior pituitary. As I said before, the anterior pituitary is divided into the pars distalis, tuberalis, and intermedia. The pars distalis is the largest part of the pituitary gland, and it arises from the anterior wall of the Rathke's pouch. It is composed of cords of epithelial cells, individually specialized to secrete trophic hormones, which act on various target organs. The pars tuberalis is the part of the adenohypophysis, which surrounds the anterior aspect of the infundibular stalk, and is between the tuberalis and infundibular stalk, which lies the hypophyseal portal system. The infundibular stalk connects the posterior pituitary to the tuber cinereum on the floor of the third ventricle. And this contains nerve fibers where its cell bodies are located in the hypothalamus. The pars intermedia is a thin layer of epithelial cells, which is located between the pars distalis and neurohypophysis. It arises from the posterior wall of Rathke's pouch and contains vestigial lumina of Rathke's pouch, which appears as narrow vesicles of variable length. These may give rise to Rathke's cleft cysts, otherwise known as intermedia cysts. The posterior pituitary, otherwise known as the neurohypophysis, is a direct extension from the hypothalamus, and it is connected to it via the infundibular stalk, which is also considered part of the neurohypophysis. The infundibulum extends from the tuber cinereum and pierces the diaphragm ocelli before being surrounded by the pars tuberalis. So the two hormones, oxytocin and antidiuretic hormones, are synthesized in the hypothalamus and travel down the stalk to be released into the posterior pituitary. Now we will just go through the cellular and paracellular relations. So these are very complex, compact anatomical crossroads of structures that surround the pituitary gland. The sella turcica, or the cellar region, this is a bony saddle-shaped structure in the sphenoid bone, which contains the pituitary gland and a dura covering the diaphragm ocella, as I would have discussed from before. The suprasellar region, which is above the diaphragm ocella, contains the pituitary stalk, the optic chiasm, the hypothalamus, the circle of Willis, and the floor of the third ventricle. The paracellar region, otherwise known as the cavernous sinuses, are situated on both sides of the cellae. So these are large venous lakes that contain the internal carotid arteries and several cranial nerves. So along the lateral wall, we would have cranial nerves 3, which is the oculomotor, and 4, the trochlea, and 2 branches of the trigeminal nerve, so the ophthalmic and the maxillary branches. Within the sinus, there's the 6th cranial nerve, or the abducens nerve, and the cavernous segment of the internal carotid artery. The sphenoid sinus lies inferiorly and anteriorly, which is crucial for the transsphenoidal surgical approach to the pituitary gland. So lesions in this area will be clinically significant. So if we have pituitary adenomas or craniopharyngiomas, Patients would present with visual defects due to compression of the optic chiasm. They could have endocrine dysfunction or diplopia, and certain imaging like MRI and CT scans would be essential to diagnose the structures in this region. So moving on to the blood supply of the pituitary, it has quite a unique and complex vascular supply. This supply facilitates the communication between the hypothalamus and the pituitary gland. So both lobes, the anterior and posterior, drain via anterior and posterior hypophyseal veins, but the arterial supply differs. So for the anterior pituitary, it receives blood from the superior hypophyseal artery, which is a branch of the internal carotid artery. This artery first forms a primary capillary plexus around the hypothalamus, and blood from this plexus drains into the portal veins that deliver it to a secondary capillary plexus in the anterior pituitary. This hypophyseal portal system enables hypothalamic releasing and inhibiting hormones to directly influence the anterior pituitary secretion. For the posterior pituitary, posterior pituitary and infundibulum receive blood from multiple arteries, mainly the superior hypophyseal, infundibular, and inferior hypophyseal arteries. Now we can take a closer look at the microanatomy or the histology of the pituitary gland. So the anterior pituitary contains three divisions: the pars distalis, pars tuberalis, and the pars intermedia. The pars distalis comprises most of the anterior lobe, about 75%, and contains two broad cell types. These are chromophils and chromophobes. So chromophils stain with hematoxylin and eosin and contain 5 types of endocrine cells that secrete hormones, and chromophobes stain poorly with hematoxylin and eosin and do not secrete any hormones. So looking a little closer at the chromophils, they would be broken down into the acidophils and the basophils. So the acidophils would stain pinkish red with H&E, and these contain the somatotrophs, which secrete growth hormone, and the mammotrophs, which secrete prolactin. The basophils stain bluish purple with hematoxylin and eosin, and these contain the corticotropes, which secretes adrenocorticotropic hormone, thyrotropes, which secretes thyroid-stimulating hormone, and the gonadotropes, which secrete FSH and LH. So the pars intermedia is a thin remnant. It takes up about less than 2% of the surface of the pituitary, and it is an interface between the anterior and the posterior lobes that contains numerous colloid filled cysts, which are the Rathke cysts. The posterior pituitary contains axons from the hypothalamus that release hormones into the capillary of the pars nervosa. It contains pituicytes, which are nuclei that belong to glial cells, and herring bodies, which are dilations of axons filled with neurosecretion vesicles. Just to go into the anatomy of the hypothalamus. So the hypothalamus is part of the diencephalon that extends from the region of the optic chiasma to the caudal border of the mammillary bodies, and it lies below the thalamus and forms the floor and inferior part of the lateral walls of the third ventricle. Microscopically, the hypothalamus is composed of small nerve cells that are arranged in groups of nuclei, many of which are not clearly segregated from one another. And it is characterized as a bilateral group of nuclei that surround the mammillary bodies. The three main regions of the hypothalamus would be the anterior, middle, and the posterior regions, each of which would serve a different physiologic function. Right? Just to further go into the anatomy of the hypothalamus, we can break it into the medial zone, and they will have certain nuclei, like part of the preoptic nucleus, the anterior nucleus, part of the suprachiasmatic nucleus, etc. In the lateral zone, the hypothalamic nuclei would be recognized from anterior to posterior. You will have part of the preoptic nucleus, part of the suprachiasmatic nucleus, supraoptic nucleus, the lateral nucleus, and the lateral tuberal nuclei. So just to note, some of these nuclei, such as the preoptic nucleus and the suprachiasmatic nucleus, would overlap both zones. And it should be noted that most of these nuclei don't have defined boundaries. The hypothalamus is connected to the pituitary gland by two main pathways. The first one being the hypothalamo-hypophyseal tract, which are nerve fibers that travel from the supraoptic and paraventricular nuclei to the posterior lobe of the pituitary gland, and the hypophyseal portal tract, which contains long and short portal blood vessels that connect the sinusoids in the median eminence of the infundibulum with the capillary plexus is in the anterior lobe of the pituitary. Just to go a little further into those tracts, so the hypophyseal tract is responsible for the transport of hormones, vasopressin and oxytocin. So these two hormones are synthesized in the nerve cells of the supraoptic and the paraventricular nuclei, respectively. The hormones are passed along the axons together with carrier proteins, which are called neurophyzins, and are released into the axon terminals. It's here in these axon terminals, the hormones would then be absorbed into the bloodstream in fenestrated capillaries of the posterior lobe of the hypophysis. Antidiuretic hormone is produced mainly in the nerve cells of the supraoptic nucleus, and its function would be to cause vasoconstriction, and it also has important antidiuretic function. The supraoptic nucleus, which produces the vasopressin, acts as an osmoreceptor. So if the osmotic pressure of the blood circulating through the nucleus is too high, the nerve cells would increase the production of vasopressin, and the effect of this hormone will increase the reabsorption of water from the kidney, and the osmotic pressure of the blood will return to normal limits. The other hormone is oxytocin, which is produced mainly in the paraventricular nucleus, which oxytocin would stimulate the contraction of smooth muscles of the uterus and cause the contraction of myoepithelial cells that surround the alveolar and ducts of the breast for milk ejection. The hypophyseal portal system is related to the anterior pituitary neurosecretory cells situated mainly in the medial zone of the hypothalamus, and this will be responsible for the production of the releasing and release inhibiting hormones. The hormones will be packaged into granules and are transported along the axons of these cells into the median eminence of the infundibulum. And here the granules will be released by exocytosis onto the fenestrated capillaries at the upper end of the hypophyseal portal system. So this system is formed on each side from the superior hypophyseal artery, which is a branch of the internal carotid artery. The artery will enter the median eminence and divide into tufts of capillaries, and it's these capillaries that will drain into the long and short descending vessels that end in the anterior lobe of the pituitary. Right, so this is just a table that summarizes the releasing and release inhibiting hormones, which are carried in the hypophyseal portal system from the hypothalamus to the anterior lobe of the pituitary. Excuse me. So some of the releasing hormones that stimulate the production and release of ACTH, or adrenocorticotropic hormone, follicle stimulating hormone, luteinizing hormone, thyrotropic hormone, thyroid stimulating hormone, and growth hormone. The release of inhibiting hormones will inhibit the release of melanocytic stimulating hormone and luteotropic hormone. So luteotropic hormone is also known as the lactogenic hormone prolactin, and this would stimulate the corpus luteum to secrete progesterone and the mammary gland to produce milk. The growth hormone inhibitory hormone, or somatostatin, would inhibit the release of growth hormone. So just now for a closer look at the production of cortisol. So just recapping, the paraventricular nucleus of the hypothalamus is the main control center of the H3 axis, and it receives input from other centers. So from the suprachiasmatic nucleus, this acts as the body's biologic clock. So it provides diurnal information, which modulate inhibitory gain to the paraventricular nucleus. It results in low activation during periods of sleep, increasing in anticipation of awakening and peaking in the morning. So this is the basis for the circadian rhythm. I have another slide that will just show a bit of the circadian rhythm. Brainstem nuclei would deliver information from the physiologic changes such as hypotension or inflammation, and the limbic region would provide the stimulation from cognitive or emotional stressors. The parvocellular neurons would synthesize corticotropin-releasing hormone, which is secreted from the median eminence of the hypothalamus into the hypophyseal portal circulation. And this CRH would act on corticotropes in the anterior pituitary, prompting secretion of ACTH into the systemic circulation. This in turn would stimulate the release of cortisol from the zona fasciculata of the adrenal cortex. Cortisol is synthesized de novo, is secreted, and circulating free cortisol then would exert a negative feedback effect on the pituitary to reduce the ACTH and inhibit CRH release from the parvocellular neurons. All right, so this is the graph that demonstrates the circadian rhythm of cortisol production. So this is basically high early in the morning for the cortisol awakening response, and the levels typically will increase by 50 to 60% in the 30 to 40 minutes after waking, and then they will decline from high morning levels to low evening, nighttime nadir. So ACTH levels, if measured, tend to follow a similar pattern. All right, so just to move on to the production of ACTH. So ACTH is a polypeptide that is synthesized from a precursor molecule called propiomelanocortin, or POMC for short. The cleavage of POMC also gives rise to other hormones, including the melanocyte-stimulating hormone and endorphins. Secretion is increased by stress or physiologic or physical. So stress, which will either be physiologic or physical. The secretion is inhibited by cortisol negative feedback as described. So lack of cortisol production, such as in adrenal failure or after adrenalectomy, would lead to increase in plasma ACTH concentrations. This increase will also lead to increase in MSH and lead to increased binding of melanocortin 1 receptor on melanocytes, leading to hyperpigmentation. So the ACTH, when released, it acts on the adrenal cortex via interaction with cell surface G protein coupled receptors, leading to stimulation of cyclic AMP production and eventual cortisol production. Just a brief overview of the adrenal glands. So they are paired triangular retroperitoneal endocrine organs, which are situated atop each kidney. They consist of an outer mesoderm-derived cortex, which produces the steroid hormones, cortisol, aldosterone, and androgens, and an inner ectoderm-derived medulla, which secretes catecholamines, the adrenaline and noradrenaline. So the cortex has 3 zones, as we know: the zona glomerulosa, fasciculata, and reticularis. The zona glomerulosa is usually under control of the renin, angiotensin, aldosterone system. And the zona fasciculata and reticularis are under influence of ACTH. So this is an image that's going through the stress response. So it could be broken up into the immediate or chronic. So immediate would be sympathetic adrenal medullary axis activation, which happens acutely or immediately. The sympathetic nervous system would stimulate the adrenal medulla to release adrenaline and noradrenaline. And the chronic phase, which will be the HPA axis, the hypothalamus signals the pituitary to release the ACTH, which prompts the adrenal cortex to release cortisol and sustains energy supply by increasing glucose into the bloodstream. They both will have similar effects on the different systems, such as the cardiovascular system. You'll have increased heart rate, increased cardiac output, increased blood pressure. Respiratory system, you'll have rapid breathing, bronchodilation to increase oxygen intake, and musculoskeletal will have increased muscle tension. Pupils could dilate to improve vision, and blood flow will be redirected away from the digestive organs and the skin towards the brain and the skeletal muscles. So this is a table just showing some of the different types of pituitary tumors, both functioning and non-functioning types. And in this slide, we will describe this function of the HPA axis, which can manifest as adrenal insufficiency. Some of the main findings of adrenal insufficiency would be chronic fatigue, muscle weakness, unexplained weight loss, anorexia, could have abdominal pain, hyperpigmentation, and postural hypotension. So there are three main types of adrenal insufficiency. The first, or primary adrenal insufficiency, otherwise known as Addison's disease. The main location of the failure, as seen in the image on the left, would be the adrenal glands themselves failing to produce sufficient glucocorticoids like cortisol and or mineralocorticoids like aldosterone. It's commonly caused by autoimmune adrenalitis, which is the most common cause, but there are other causes such as infection, like tuberculosis, adrenal metastasis, lymphoma. You can have hemorrhage, such as seen in Waterhouse-Friderichsen syndrome, or bilateral adrenalectomy. The key characteristics for this would be low serum cortisol levels combined with a high ACTH level. Secondary adrenal insufficiency, the location of the failure would be the pituitary gland, which would cause decreased ACTH production. So the low ACTH production will lead to low cortisol production. And the common causes of this would be pituitary tumors, metastasis, pituitary surgery, if there's radiation, head trauma, pituitary apoplexy or Sheehan syndrome, and inflammatory diseases. I'm moving on to the last type, or tertiary adrenal insufficiency. The location of the failure is higher up, the hypothalamus, which results in decreased corticotropin releasing hormone. It's similar to secondary. There will be low ACTH, low cortisol, and low CRH as well. Common causes of this would be abrupt withdrawal or cessation of chronic glucocorticoid therapy, such as stopping prednisolone. So adrenal crisis. So what is adrenal crisis? So it is a life-threatening condition that typically occurs in individuals with already marginal adrenocortical function, who are subjected to significant acute stress or such as infection or trauma. Sudden or complete loss of adrenal function, as occurs with Waterhouse-Friderichsen syndrome, and certain hypocoagulable states can also manifest with adrenal crisis. The findings would be a patient in shock, complaining of abdominal pain, maybe fever, nausea, and vomiting. They have electrolyte disturbances, and occasionally it could be hypoglycemic. Mineralocorticoid deficiency would result in an inability to maintain sodium and intravascular volume, and is the primary pathogenic mechanism. These patients should be treated for suspected adrenal crisis with no delay in results for diagnostic testing. So treatment for this crisis would center around large volume intravenous resuscitation with isotonic saline, glucocorticoid administration in the form of hydrocortisone, 100 milligrams IV bolus, followed by 75 every 8 hours, or dexamethasone, it could be 4 milligrams intravenously daily. So dexamethasone is long-acting and carries the advantage of not interfering with biochemical assays of endogenous glucocorticoid production. So ironically, mineral corticoid replacement is not an early priority because the sodium and fluid retaining effects of mineral corticoids would not be manifested until several days after administration. Right, so moving on to the opposite side of the spectrum, to hypocortisolism. So Cushing syndrome is a rare hormonal disorder caused by long-term excessive exposure to high levels of cortisol, which may present with a typical collection of signs and symptoms, such as we see in the image here. So the patient could have moon faces, central adiposity, buffalo hump, abdominal striae, thin wrinkled skin. So these are as a consequence of cortisol excess. These patients may also have emotional disturbances, osteoporosis, cardiac hypertrophy, hypertension, etc. Right, so just going through some of the causes, it could be divided into endogenous versus exogenous causes. So exogenous or iatrogenic hypocortisolism is the most common cause, and it arises from the therapeutic use of synthetic corticosteroids for certain medical conditions like asthma or autoimmune conditions. Endogenous hypercortisolism or Cushing syndrome can be broken down into ACTH dependent or ACTH independent. So the majority, 80% of endogenous cases will be ACTH dependent. Could be Cushing disease, which is caused by benign pituitary adenoma, which produces excess ACTH, which stimulates the adrenal glands to overproduce cortisol. Or there could be ectopic ACTH syndrome, where non-pituitary tumors, such as seen in paraneoplastic syndromes with small cell lung cancer, produce excess adrenocorticotropin hormone and then cause excessive cortisol hormone. ACTH independent causes, which would be about 20% of the endogenous cases, would be seen with adrenal adenoma or carcinoma, or there's a tumor within the adrenal gland which directly produces excess cortisol, or adrenal hyperplasia, which can either be primary nodular hyperplasia of the adrenal glands. This is a diagnostic algorithm, or one of the diagnostic algorithms for diagnosing Cushing syndrome. Just to go through it briefly. Firstly, you would need to exclude exogenous administration of steroid, which, as I said, is the most common cause. We would move on to an overnight dexamethasone suppression test that could be done twice, or a midnight salivary test that could be done 3 times, or a urine-free cortisol test. If these are negative, then we can rule out Cushing syndrome. If positive, then we would need to do a midnight cortisol and or a low-dose dexamethasone suppression test, which has a higher specificity than the overnight dexamethasone suppression test. Positive test would confirm Cushing syndrome. Then we want to measure the ACTH levels to see if there's ACTH dependent or independent. If the ACTH is low, we recommend an adrenal CT scan will be done to assess for adrenal abnormality. And if the ACTH is high, then we'd want to consider doing imaging of the brain with a pituitary MRI, plus testing for corticotropin releasing hormone. If there's a pituitary lesion, it would confirm Cushing disease. If there's a normal pituitary, that would prompt assessment with bilateral inferior petrosal sinus sampling. And it is stated that this sampling remains one of the gold standard diagnostic tests for Cushing's disease. For assessment of ectopic ACTH, a CT, a whole body CT, plus or minus a creative scan could be done as well. All right, briefly, just to go over the treatment for hypercortisolism. First line treatment would be surgical resection, which could be curative. So Cushing disease would be transsphenoidal surgery, adrenal tumor, we can do laparoscopic adrenalectomy, or if there's ectopic ACTH, surgical resection of the ACTH producing tumor can be done. Second line or adjunctive therapy. So if surgery fails or if there's recurrence after an operation, you can do a repeat operation or consider pituitary radiation or medical therapy. If severe rapid control is needed, fast-acting medications like ketoconazole or meterapone can be used. Targeted agents like cabergoline can be used mainly for Cushing's disease. Right, so HPA axis dysfunction due to dysregulation of cortisol from prolonged exposure to stress and trauma can manifest as other conditions stated here, like mental health disorders, major depressive disorder, generalized anxiety. It can cause metabolic endocrine issues like diabetes, obesity, chronic fatigue and pain, immune system dysfunction, like increased inflammation or susceptibility to infections, autoimmune diseases like lupus or Crohn's disease, cardiovascular conditions such as high blood pressure, and neurodegenerative diseases, certain links to Alzheimer's disease and cognitive decline due to elevated cortisol have been found as well. All right, so just to conclude in summary, the HPA axis is the primary neuroendocrine system for the response to stress, and this function can be manifested as steroid excess or with adrenal failure. These are my references, and thank you very much.